when we treat patients in accelerated protocols, we're going to first evaluate them, just like we've said in previously with a CT, seeing if we have ability to find bone to place the implant in a restoration-driven manner. So it's not going to be site-driven. It's going to be, is this bone in a position that's going to allow us to restore the implant as planned? And as well as embrace the other philosophies, is there a buccal plate there, can we position an implant with a horizontal defect dimension? So this patient on the left of the screen here is one that we've determined would be a type 1 placement. So it's going to be an extraction with an immediate placement, and then once we assess the stability after placement, move forward with immediate loading. Okay, so we can go into surgery planning for immediate loading, but if we don't have the stability achieved that we seek, then we're going to submerge that implant or go with a custom healing abutment, but we're not going to put that implant in function. So you can see an Osstell smart peg was used. We determined that this implant had good stability. And now we're going to move forward with actually a prefabricated restoration. This was a fully digital workflow, and we had everything prefabricated prior to going to surgery. Now, on this patient on the right, you could see this is a type 2 placement. So the tooth was extracted. We're coming back at a later date. This is going to be closer to 10 weeks. You can see the amount of tissue healing that we've had here. And actually in these situations where we have little or no facial plate, Vivian Shapway highlighted this very nicely in her publications, where you actually get a thickening of the tissue there. So you can take a patient with a thinner biotype and convert them to a thicker biotype by taking them from a type 1 placement to a type 2 or type 3 placement. So this is a CT assisted template, right? We did the first guide drill through that, and then the implant was placed in that osteotomy, and then we're going through the process of doing a contour augmentation technique as published by Danny Boozer and colleagues over the years. So this implant was tested as well for stability. Now, the important thing is, and this will be highlighted in the Osstell Connect, is whether we can use the Osstell Smart Peg at the time of placement or we use it at the time of loading, we always want to record these implants, because if we don't feel comfortable taking a measurement at the time of placement, we still are going to want to have a baseline when we move forward with the loading of this implant. So you can see we're able to get a baseline on that. Fast forwarding to accelerated treatment protocols and outcomes, you can see the patient on the left there. She had a restoration. We went into, it was immediate load, so we brought her back in 6 to 8 weeks, where we moved forward with the definitive restoration. Tissues were shaped at that point. We captured the tissues. And here in this situation, we had a healed site that now had an implant placed that had a graft placed over it. So we're going to let this patient heal for a longer period of time and then uncover and load that patient at the uncovery visit. Once we've done an Osstell to confirm that we're happy with the stability of that implant. Now, I'll talk a little bit more later that the decision making is not just solely on Osstell readings. I mean, you have to use your clinical experience. We look at radiographs. We look at the clinical appearance of the implant, palpation, percussion as well, and then the implant stability. So these are all things that we evaluate. But the ISQ readings, I think, are a very good tool in seeing the progression of that implant or regression of that implant over time.